Yes.
Okay, great. Well, welcome to my talk on PCD, the basics. And we'll start by the basics of cilia. What are they and how do they work? A little bit about the usual symptoms of PCD, and perhaps a new topic for some of you: how do we measure outcomes in PCD? And that will be both related to patient-reported outcomes and what we can measure in the laboratory during ordinary patient follow-up, and a little bit about the longer-term outlook for people with PCD. So the first thing is PCD. What does it mean? What's in a name? And P stands for primary. And I've put this in because some people have asked about secondary ciliary dyskinesia. Primary means that the body is unable to make normal cilia. It's not that you're born with cilia that then become damaged later by an infection, for example, because then that would be a secondary ciliary problem. Ciliary just means, of course, that it's related to cilia. And cilia are tiny, tiny hair-like structures that you can only see with a microscope. And we have two types of cilia, one that are moving, and that's about PCD, moving cilia. And you can have cilia that are sensory, that can detect changes, for example, in fluid flow. They're not usually involved in PCD. Dyskinesia means abnormal movement. So the cilia cannot move normally. And another word for movement is motility. So that doctors or scientists often refer to PCD as a motile ciliopathy, meaning that it is a disease that affects moving cilia. So where in the body do we find these cilia? We can find them in the brain. You will all know that we find them in the nose, the sinuses, the middle ear, moving down into the lower airways. The sperm, in fact, are a type of cilia. And we also have sperm in the oviduct. The oviduct is the tube that goes from the ovaries down to the womb or the uterus. And just to give you an idea of how small these cilia are, here we have a picture of cells in the airway. Now this, I don't know, the arrow has disappeared, but here you can see that that is one cell in the airway, and we have 400 cells per centimeter. So they're also very small. And on top of each of these cells, we have about 200 cilia, lots of cilia. So there are millions of cilia in the body. And what they do is they all beat together. And I've got some videos here to show you what that looks like. On the top panel, you can see the cells here, a little bit like the cells in the top picture. And on top of the cells, you can see these cilia all beating together. And on the top here are some particles being moved along by the cilia. And then if you contrast that with this panel down here, in the lower panel of a patient with PCD, you can see the cilia, but there's absolutely no movement of these cilia. And the particles are standing still in the mucus. Nothing is moving. So what do motile cilia do? So I've just hinted that cilia move mucus and particles. These particles can be dust or pollen, things that we breathe in, bacteria, viruses. So the cilia move these particles in the mucus from the lungs up to the throat, where it is normally swallowed. And people normally produce about an egg cupful of sputum every day without knowing it. The sinuses, cilia also move secretions from the sinuses and the nose to the throat, where it's also swallowed. But if you don't have PCD, you don't really notice that. So people with PCD cannot move this mucus. It collects in the airways, the upper and lower airways, where it stagnates, it pools, and the only way to get rid of it is either to cough it out or blow it out. And this is important, and I'll talk a bit more about that later. Mucus or fluid also accumulates in the middle ear and may cause hearing loss and infections. And the cilia in the oviduct, which is the tube that goes from the ovaries down to the womb, they help move the egg towards the womb, so that some women with PCD can have trouble conceiving because the egg isn't moving normally. And similarly with sperm, this is the sperm tail here, and this is the head of the sperm here. The sperm tail swims a bit like cilia move. Not all men, but most men with PCD have sperm that can't swim, and therefore they cannot move towards the egg and fertilize it. And you will hear more about infertility and PCD later from Joanna Raidt. Now, the reason why stagnation or pooling of mucus in the airways matters is because it acts as a reservoir for bugs or bacteria and causes recurrent infection. And this is the nub of the problem with PCD. So the mucus gland here secretes the mucus, which just lies in the airways, becomes infected, sets up inflammation, causes airway damage, and you get a repeated cycle of infection and airway damage, eventually leading to something called bronchiectasis in most people. And bronchiectasis means that the airway is much wider than normal, the wall is thickened, and it produces even more mucus than a normal airway. The other reason that mucus stagnation matters is that thick mucus can form plugs that block the airways and cause parts of the lung to collapse, to lose air and then collapse. And this is something called atelectasis. And you can see it on X-rays, for example, as white patches here. This is a newborn with PCD. So atelectasis refers to a collapsed part of lung that has lost air. Importantly, it can become permanent. And some of you have probably had a bronchoscopy, for example, to try and remove mucus plugs to inflate areas of the lung again. But motile cilia do other things too. So they're important before we're even born, and they are responsible for orientation of the organs in the chest and in the abdomen. So normally we have a left lung on the left and a right lung on the right, with the heart towards the left here. We have a liver on the right-hand side and a spleen on the left. And here we have our colon, or our guts. And dangling down at the bottom here, we have the appendix. So this is what's called normal situs, and that is present in about half of people with PCD. But about 40 to 50% of people have something called Cartagena syndrome. And what that means is that the organs in the chest and the abdomen are mirrored. So that the left lung is now on the right and the right lung on the left. The heart is on the right and vice versa. So the spleen is now on the right. And importantly, the appendix is on the left. And then we have another condition called heterotaxy or situs ambiguous. And what that means is that the position of the organs is a bit jumbled. And this occurs into 6 to 12% of people with PCD. And this is important, as I'll tell you a little bit now. Heterotaxy is associated with an increased risk of congenital heart disease. That means problems with the heart that you're born with. You may also have problems with the rhythm of the heart, the way it beats. The spleen may be absent, and that's an infection risk and needs to be treated with permanent antibiotics. But importantly, some of you with heterotaxy may have lots of mini spleens, small spleens, but that doesn't mean to say they work normally. So if you're somebody with mini spleens, there needs to be a test done to make sure that your spleens are working normally. The other thing with heterotaxy is that the intestine may be rotated differently and at increased risk of twisting and obstruction, and that's important to know. For people with both heterotaxy and situs inversus, appendicitis may be difficult for a doctor to diagnose, so you need to be aware of that as well. And if for any reason you might ever need CPR, for example, if you're involved in a car accident, it's important to have some way of, some people wear a medic alert bracelet, for example, or it's in electronic medical records, that the heart is on the other side of the body. That doesn't mean to say that CPR would be unsuccessful, but it might be difficult to interpret electrical signals from the heart when you're using a defibrillator. So that all patients diagnosed with PCD, ideally, particularly if they have situs ambiguous or heterotaxy, should have an ultrasound of the heart and abdomen. Now, the other thing about PCD is that we know that it's probably much more common than we originally thought. And it's now thought about 1 in every 7,500 people has PCD. And that translates to about 13 people per 100,000 or 130 per million. Now, if we look over here, we've got some figures from European PCD registries, Denmark at the top and Norway at the bottom, with the total number of patients diagnosed in the whole country. If we move over to this side and look at the total number of patients diagnosed in these countries, it's the equivalent of 2.3 people per 100,000 and not the 13 we would expect. Norway is doing very badly at only 1.7 people per 100,000 when we would expect 13. And that situation is even worse if you look at people over the age of 40. For example, here for Norway, only 0.2 people per 100,000 diagnosed. So we still have a long way to go when it comes to raising awareness of PCD and getting it diagnosed. And what causes PCD? Marie Legendre will say much more about the genetics of PCD, but I will just touch on this briefly to say that PCD is a genetic disease. We inherit it from our parents, and mostly we inherit a faulty gene from each of our parents. And a gene is a segment of DNA, and it provides codes to make proteins. So the first gene for PCD was discovered only in 2001, so not very long ago. We now know of more than 50 genes that are known to cause PCD, but there are probably at least 250. So there is still a lot of genes to be discovered. The other thing about the mutations or the mistakes in the coding in our genes is that most of these gene mutations are private, meaning that they are found only in that individual or in that individual's family or in a small number of people. So it's difficult sometimes to know whether or not the mutation causes the disease or is harmless. And some of you may have been in that situation. But nonetheless, it's important for all to have a genetic test. You can still make the diagnosis of PCD without a genetic test. Now, this slide looks very complicated, but I'll take you through it. We have the airway cells that we saw just now with all these cilia lying on top of them. The important thing about cilia is that they can only work, they can only function with their normal beating if the internal structure of the cilium is intact. It must be as it should be, otherwise it can't work. So if you cut a cilia across like this and look at what the cilia looks like inside, it has this structure always if it's normal. And we have these pairs of tubes which will run around the outside, 9 pairs of these tubes. They're all connected to one another, and they're all connected to this central pair of tubes here. It's a bit like a bicycle wheel. And there are also these structures here, which are arms. We have outer Danaan arms and inner Danaan arms, and you've probably heard about these. These are the internal motors of the cilia. So instead of, I think about cilia as being a bit like a machine, but instead of using plastic or metal to build a machine, we use proteins in the body to build a machine. And if we look at these 2 tubules here, we've taken a pair of tubes here and a pair of tubes here, lying on top of one another. And here they're connected by an outer Danaan arm, and we have 4 of those Danaan arms here. And what they do is slide the tubules over one another and cause them to bend and move. And that's their motor effect. So if you have a mutation, for example, in a gene called DNAH5, you can't make these outer Danaan arms, and it means the tubules can't slide over one another and they can't move. So even a small defect like that is enough to disrupt the movement of the cilia. So DNAH5 is said to be a milder mutation. Other mutations cause disruption of the whole internal structure of the cilium. It tends to fall together. And that occurs with mutations such as CCDC39 and 40, for example. And then I just had this sort of 3D structure of the cilium here. This is the same with the tubes around the outside, these central tubes in the middle. And this is the cilium attaching to the cell. And this is a transport hub, which has been likened to a train station where cargo is transported for the needs of the cilium up through the cilium to the tip. So they're very complicated structures, and that's why they're so vulnerable. So how do we diagnose PCD? History taking and clinical findings, but particularly history taking, is paramount in trying to decide whether or not somebody should be worked up for PCD or not, or whether they have PCD in the absence of confirmatory tests. We measure nasal nitric oxide, a gas from the nose and sinuses. It's typically low, but can be normal. So normal result does not exclude PCD. We could look at how the cilia beat using light microscopy, so using a microscope to look at the cilia beating. But this is a difficult test to interpret, and not every center can do this. We don't do this in Norway, for example. And then we can look at the internal structure of the cilia using a powerful microscope called an electron microscope. And this is like the diagram I just showed you in the previous slide, and you might be able to make out some inner arms here and some outer arms here. But this can be normal in about 35% of people with PCD, particularly, for example, with a gene called DNAH11. We can stain proteins in the cilia. You may have heard of immunofluorescence. So if we stain with different colors, we can see whether or not the protein is absent or present, and that can help us find a gene. And then there was the genetic testing we talked about, and not knowing whether or not, in about 20% of cases, whether or not the mutation is pathogenic. That is known as a variant of unknown significance, a VUS, if you've heard of that. So that in some cases we end up making a highly likely diagnosis of PCD without being able to confirm it. Now, I've just put a couple of pictures of chest CT scans. I think it's certainly for doctors looking after people with PCD, it's very important to know what the scans look like. But this is to show you why early diagnosis, and I think by inference, why early treatment is so important. We have scans from two people here, and the top panel here is a refugee who came to Norway at the age of 15, undiagnosed and untreated. In the second panel here at the bottom, we have a patient who was diagnosed after birth because his sister had PCD, so he was treated right from birth. And just to show you what bronchiectasis looks like, this is a slice through the chest with the breastbone here, the heart here, the backbone here. And we have a triangular area here where there is inflamed tissue in white and dilated airways here in black. And if you look down here on the left-hand side at the bottom of the left lung, there are large areas where there is bronchiectasis, so dilated airways that don't function, lots of mucus plugging the white areas and inflammation. And if you compare that with the panel below, there is no inflammation or bronchiectasis that we can see in this picture here. If we move over to the bottom of the lungs, we can see very minor bronchiectasis at the bottom here, but that's the only sign of bronchiectasis. So early diagnosis and treatment really does matter. And just looking at symptoms with PCD, this looks a bit complicated, but we're just going to look at upper airway symptoms and look at the yellow panels with children and adults and nasal symptoms. So about 2/3 of children have daily nasal symptoms, rising to about 3/4 of adults. If we look at ear pain, it's not so common in children. About 1 in 5 children have daily ear pain, and about 1 in 3 adults. Hearing problems, about 15% of children will have hearing problems. Previously, we thought that hearing got better as people got older, but that does not seem to be the case. So about 1/3 of adults will report hearing problems. And if we look at the lower airways, we're always taught as doctors that people with PCD cough every day, but patients don't always tell us that. So we have children here reporting cough. About 2/3 of children will report a daily cough. Similar proportion of adults. Similarly, when we talk about sputum production, but that's sometimes difficult to determine in children, but we would expect people with PCD to produce sputum daily. And shortness of breath is not such a problem in children. About 10% or 1 in 10 children will report shortness of breath, but it is more common in adult patients. Importantly, we need to know how to measure the impact of PCD on patients' health. We can do that by the instruments we have in the lab, and I'll talk about that, lung function, but it's important to know what the patient reports or what the patient feels. So there are now quality of life assessment tools which are PCD specific, looking at the impact of symptoms, and that's related to airways, hearing, and fertility, the impact of treatment on the patient's well-being, and on their emotional and social functioning. And not surprisingly, older age has a negative impact. That might be because symptoms become more severe with age. It's related to treatment burden, chest symptoms, and lung function. So it's important that doctors know and ask about these. And even more important is that there are increased rates of anxiety and depression in all age groups and in the parents of children. So access to a psychologist is important for people with PCD. So other things that we can measure include growth in children, BMI or body mass index in adults. We can measure lung function by blowing into a spirometer. We can take CT scans of the sinuses and the lungs to look at structural changes associated with PCD, so the injury to tissues caused by PCD. We can take culture of the mucus, so we can grow mucus in the lab to see which bugs we get from mucus in the lungs and the nose. And it's important that that's done when you go to the clinic for your routine follow-up, and if possible, when you're sick. The need for lung transplantation is also a measure of lung health, and I'll just spend a little bit of time on that in a moment. And life expectancy, which really we don't know much about, but for many people with PCD is probably normal. And influences on disease severity include, as I alluded to earlier, which gene is causing the PCD. So these, as I mentioned, are more severe. DNA H11 is milder. Agic diagnosis, treatment provided. The bacteria that grow in the lung have an impact. And if we look at this graph here, we have percentages along this axis here. And we have age groups along the bottom here. So children is everything to the left of this line here. And we have 3 bugs which are important in childhood. We have Staph aureus, Haemophilus influenzae, and Pseudomonas aeruginosa. And it is Pseudomonas which becomes the most common bug as you get older with PCD. And it is associated perhaps with poorer lung function, particularly in women. And you can see here for the over 45s, about at least half of people with PCD have infection with Pseudomonas aeruginosa, which can be treated. Nutritional status is also important, but it's a bit difficult to know which is chicken and which is egg with nutritional status. Longer term outcome, we don't really have the studies to tell us about longer term outcome in PCD, but these will come with time. We have shorter term studies looking at lung function. This looks very complicated, but this is just, it's not. And here we have a measure of lung function along here. This is % of normal. So 100% is about normal. 90% here is still normal. And these are patients who have lost their outer Danaan arms, as I showed you in the slide earlier. And this is the age of the patient here, 21. Starting in childhood, you can see lung function is normal and remains sort of within the normal range, not far below normal, throughout childhood and into early adulthood. But one thing you will notice is that there is a huge range of lung function from supernormal to below normal. And the same if you're missing your outer and your inner Danaan arms here. And where the internal structure of the cilia is disrupted, like CCDC 39 or 40, you can see that lung function starts off a bit lower and falls off a bit more steeply as you get older to the age of 18 here. But there is still a huge range with, again, supernormal lung function and lower lung function. And interestingly, the point about having normal structure, these patients with PCD have normal internal structure on electron microscopy and completely normal lung function that doesn't appear to get worse with age. But these are short-term studies. They're stopping at the age of 21. And just to finish, to talk a little bit about lung transplantation in PCD, the first thing to say is that it's uncommon. Not many people have the need for lung transplantation in PCD. This is a 25-year study where 36 patients with PCD underwent lung transplantation. 19 of them had normal situs, and the others had situs abnormalities, either inversus or jumbled up organs. And this is life expectancy. This might seem a bit scary. This is 100%, so everybody surviving. And this is time along here, years, from 0 to 20 years. After 8 years, 50% of people were still alive. And for lung transplantation, that is pretty good and equivalent to other causes of the need for lung transplantation, such as cystic fibrosis or other serious lung diseases. And it's not much different for situs inversus. So to summarize and finish, PCD is not the mild disease it was once said to be, but disease symptoms and severity are highly variable. And that's something we refer to, or doctors will refer to, as clinical hetero, meaning different, heterogeneity. And PCD is often compared with cystic fibrosis, but it's not like cystic fibrosis because CF is caused by just one gene, whereas PCD is caused by defects in lots and lots of different genes, which means that finding a genetic cure or gene-related therapies is difficult. We have lack of information on long-term outcome in PCD, particularly with lung function, life expectancy, and the impact on education and employment, for example, and other aspects of health, for example, bone health and cardiovascular health. And to finish, we do have good news because there is progress in gene-related therapies, and you'll hear about those later this afternoon from Marie. So thank you very much.